We are going to talk about how we identify folks who are at risk for pressure injuries. We want to be able to recognize early signs of pressure injuries because that is key for letting folks heal faster. And we want to be able to assess and stage pressure injuries so that we can come up with an appropriate treatment plan. So why is skin integrity important in spinal cord injury? It all has to do with the compromised sensation. So absolutely, the inability to recognize the warning signs that your skin is at risk is key in what happens with being really in a danger zone for getting skin breakdown. When you don't have sensation, you may not recognize if you've been in one position too long. You may not know if you have pulled up too close to a source of heat. The number of folks who I've seen with burn-related injuries because they've been too close to a heater or a fire, or they've been outside and get frostbite. Now, thermal injuries are a little bit different than what we're talking about with the pressure injury discussion today, but it is still on the spectrum of why are we worried about skin in people who have compromised sensation. It's because things can go bad fast. So when we talk about a pressure injury, I mean, really it's a newer terminology for what has previously been known as decubitus ulcers, bed sores, pressure ulcers, skin sores, and even the term pressure injuries. It's a little bit of a misnomer because it really is talking about a specific etiology of why you have skin breakdown. So when we're talking about pressure injuries, really we're talking about a loss of skin integrity because of compromised sensation. And the etiology may not be pressure, it might be friction, it might be shear. So it really is just an awareness of this is what the terminology is and how we're going to be referring to it. And the reason that it's really important is that it's super common. So we know that between 10 and 38% of folks with spinal cord injury will have an area of skin breakdown at any given point. The sad thing is that if you have a cord injury, you are almost guaranteed to, at some point in your life, deal with skin breakdown. There are pressure injuries that are described in their staging system. So the National Pressure Ulcer Association really has described a staging system so that when we communicate with each other, when we're talking about what kind of injury, we're on the same language. So I'm going to talk about that in just a second. So pressure injuries are a serious lifelong complication of spinal cord injury. And over time, with aging, it becomes even more of a risk factor. Sadly, I understand aging and skin and that it does change over time, but there's a reduction of the skin tolerance to those sources of pressure, friction, and shear. I think what I'm very aware of is that when things get to an advanced stage, that people often end up in the hospital and they're being treated for infections, they're being treated for secondary complications related to their injury, whether it's changes to their spasticity, to their autonomic nervous system control, whatever it is. And the sad thing is sometimes being in the hospital is even a more risky place for progressive skin breakdown. Being in the hospital may not be where you want to end up with skin breakdown, and that is part of the reason why prevention and early detection is so critical. So when we're talking about pressure injuries, let's just make sure we're on the same language. A stage 1 pressure injury is characterized by a red spot that does not blanch when you press on it. I am aware that we also have a broad cultural background in our practices. So that's a classic description of a red spot. For people who have higher pigmentation, so people of color, it's going to show up as brown. So it is that recognition that red is sort of that classic descriptor, but it may not be how it presents in your practice. So a stage 2 pressure injury is when you have the loss of integrity of the skin surface, and it is a partial skin injury. So it does not go all the way through into the fat layer. Stage 3 is when it actually goes into the fat layer, and then stage 4 is when it's beyond that and it gets into deeper structures, whether that is muscle, tendon, ligament, bone. And that is when you know that you're going to be in a much longer healing circumstance. There are 2 other things I want you to be aware of. There's also unstageable pressure injury, and that is when you have the top of a wound that is covered by that scab-like eschar yuck tissue, And because you can't see the wound base, you have no idea how bad, how deep, how extensive it is, or even how far it tunnels around, because you can also have something that looks like a relatively small skin opening. But when you put your probe in, you're like, oh my goodness, that is a grapefruit size underneath there. The pressure injury locations that we typically think of really depend on what surfaces you're on. So in bed, so even in acute care or when you're in emerge, if you happen to be doing an emerge shift and someone comes in on a spine board, you have to be aware that the positions that they're really going to be at risk for breaking down skin is at the sacrum. The number of butterfly-shaped wounds that I've seen from the spine boards is unfortunate, and it's all for good intentions, but it really is the challenge of the reduction of the blood flow at that deep tissue injury, or interface rather, and the good intentions of keeping to the spine stable can lead to an exposure of the sacrum. Heels are another risk point, the tip of the shoulder blades, the back of your head. So that is really the concern about the lying down on your back, so a supine position. If you're in a side position, you have the sticky outy bony bits of your greater trochanter, you can have the knees. Truly, this is a principle that is applicable for anyone who is perhaps in a compromised sensory state or who has a compromised level of alertness or level of consciousness. So the ICUs are very aware of these pressure points as well. The neuro wards where folks have had strokes, and certainly the increased prevalence of diabetes in our population with the associated neuropathy. These are all really practical, relevant principles to be aware of in practice in general. So what are the risk factors for pressure injuries? Well, the injury level certainly plays a part. So if someone has a tetraplegia versus a paraplegia, they're at higher risk. And in part, that is because of the challenges that there would be with self-mobility, readjusting position, the age of the spinal cord injury, what are the comorbidities that they're coming with. So even if someone has an incomplete spinal cord injury, if they have a pre-existing peripheral neuropathy, that too will increase their risk. Smoking, oh my goodness. It is so amazing for clinical practice to see the difference of wound healing when someone goes from being a smoker to being a non-smoker. It really is a key difference maker for managing skin integrity. So even the work that you're doing in your office about counseling for smoking cessation absolutely is critical for skin integrity. It may also be really important for surgical candidacy because surgery for skin breakdown can have its own challenges. It may be a requirement from the surgeon for the patient to actually be a non-smoker. So that really is critical. When we talk about bowel incontinence, a lot of times the wounds are in areas in the saddle area, so it's the sit bones, the ischial tuberosities. It is in the sacrum or the coccyx or the greater trochanter, and the capacity for cross-contamination from fecal incontinence is significant. And in practice, really, people assume that I talk about paralysis a lot as a spinal cord injury physician. I talk about bowel and bladder function infinitely more than I talk about weakness. And it is because of how those challenges really impact so many areas of life and health and wellness and quality of life, including the risk of non-wound healing. Same with bladder incontinence. If there's urinary leaking and you end up with skin that's really moist, it becomes fragile, you know, kind of like that prune skin maceration. You'll see that around wound edges as that white kind of goopy, thick, soft, callous look. So that is going to be a moisture issue. We've already talked about some of the differences in how skin injury presents in people of color. So being aware of that when you're doing visual inspections. This is an example of what you may see for someone who has an area of non-blanching redness. So stage 1. This does not look like a deep tissue interface injury. It's not that dark, angry, purplish discoloration. Another tip is that the shape of the redness that you see or the shape of the wound itself may actually give you information about etiology. So if you have a perfectly round wound, I think that looks more like pressure because it really is that distribution of how the arterial flow is messed up. If you have something that's more stellate or ragged, I'm starting to think, okay, this is friction and shear because it has a directionality to it. If you have an area of wound and there's a ton of tunneling where the undermining is extensive, then again, I think about sliding forces, because it's not just that direct pressure, it's that you get those shear types of forces on the subcutaneous tissue, which leads to the wound. So again, that's where the shape, size, appearance of the wound and the undermining or sinus formation can be important. So what puts someone at risk for a pressure ulcer, pressure injury? Well, unfortunately, a previous pressure injury is an indicator of risk for future pressure injury. And in part, that is because when the skin heals, it never fully reaches that same tolerance to resistance of shear, pressure, and friction force. So even when a wound closes, those first 3 months especially, wow, it still is so vulnerable for recurrent breakdown. The other thing is, if someone has had a surgical repair of a previous wound, you've already robbed from Peter to pay Paul, you've moved part of the muscle and its blood supply to cover another area. So there's already a reduction in that baseline tolerance. And there can be a point in time where you run out of places to do surgery. Muscle atrophy is a risk factor. So if you're thinking about, again, upper motor neuron versus lower motor neuron, so cord injury, you often get spasticity, which allows for some maintenance of muscle mass that covers those bony prominent areas. So even if you're thinking of gluteal mass, versus a lower motor neuron injury where the atrophy is profound, and you really notice the difference for how close to the surfaces those bony prominences are. Nutrition, how much protein is someone getting? What is their calorie intake? Are they getting the nutrients that they need? Body build. One of the unfair things about having a spinal cord injury is that you will not have the same capacity for metabolic output. So even your resting metabolic rate will shift. So the amount of calories that you can take in without increasing weight is going to be reduced. So it is so common for there to be that weight creep over time, and that can influence how easy it is to do transfers, and how you're able to really protect your skin.